the next presentation is Andrea Maier from National University of Singapore. Welcome.
Yes, thank you so much for sharing this morning with us and aging together. I have a talk about diagnostics interventions and again, for the ones who were not here on Monday, introducing the Longevity Medicine Society, a worldwide society of healthcare professionals. Scientists can also join to really shape the future of longevity medicine, really translating geroscience into clinical practice. For the ones who did not know yet, I moved from especially the University of Melbourne to the National University of Singapore, co-directing with Brian Kennedy, the Center for Healthy Longevity. Our aim is really to bring preclinical and clinical research together and implement it into clinical practice. And we are working on the pipeline to bring animal models into clinical trials, not the animal models into clinical trials, but the results. And then selectively implementing it in different phases into a hospital. Here you see on the first slide Alexandra Hospital, which is the publicly funded hospital in Singapore we are working with, and we are launching a longevity medicine clinic very, very soon in a publicly funded system, and I think that's an important step, because I think that we have diagnostics and interventions in hand already to make that move, and also to convince, hopefully, regulators to be able to have longevity medicine physician certificates, etc., and to bring qualities to the field. So we know that our organ system is going to decline. Every decade we are having more wrinkles and less muscle mass, etc. Normal medicine is dichotomizing us, as you know. There are certain cutoff points where we call a certain individual a patient, being a diabetic, being a heart failure patient, etc. It's very black and white, and I think we have to change that, and we have the opportunity to do that. And I don't think that we just do that with individuals who are at the edge of becoming a patient, to have a disease like having diabetes, and trying to convince that individual to have more physical activity, to lose a little bit of weight, to prevent diabetes. Really that now we are at the edge to optimize human function, even in the individuals who are at the best of a population of that chronological age group. And we should not start, I'm a geriatrician by training, an internal medicine specialist, and I really moved from geriatrics into, I would like really to be a pediatrician in the end, but to really move into an earlier stage of life where we can really shape the future of that body preventatively to overcome organ dysfunction and to prevent the age-related disease, hopefully at the age of 40. So this is longevity medicine. I would say we should shape. There is a society. Here's the website. Please, if you're interested, just sign up. And we need pediatricians to actually see if we can already shape the future of newborns. And I think we can do that, and there's lots of evidence. This is an important slide for our longevity center, and actually I have to update it because it's not good. At that moment in time when I made the slide, I really focused on what kind of biomarkers do we already have, what kind of MX platform should we implement at the National University of Singapore and make use of that. And of course this is looking at the microbiome, lots of omics platforms, looking at the genome and looking at the epigenome. But I think it's really important, if we are looking about phenotypic characterization of human beings, that we also include clinical data sets. We should not say, no, there's no room for a gait speed or a hand grip strength, etc. I think what we need to learn is to optimize these variables and these measurements for a much earlier age group. Look, 40 to 60-year-olds, for example. All our measurements we have are very well validated for especially 70, 80 plus individuals and quite frail individuals. So our field has to move to get more validated measures of middle-aged individuals. So we need, next to the biological phenotyping, we need clinical phenotypic characterization. And I think there is an emerging field of digitally phenotype individuals. I see lots of people people here with Oura rings, and some even have glucometers, etc., attached to their body. I think that's the way to go to understand physiology in individuals, and there was be able to intervene and to react much quicker. When I was the divisional director of medicine at the Royal Melbourne Hospital, I implemented, for example, the hospital in the home, bringing really acutely unwell individuals to their homes, monitor them remotely, and being able to act when it's actually needed. And there was saving money, bringing people home where they want to stay when they are sick. And I think we have to learn from all these kind of disciplines, and we can make it work because the infrastructure is already there. So while measuring and while adapting the intervention, I think that's very important, and measuring again. And the diagnostic should start very early and to really shape the trajectory of health. I would like to show you a couple of papers we are either in the stage of publication or which are already under review, looking at how can we make sure that we bring the best clocks into clinical practice. So here I show you one example where we used the UK Biobank, around about 150,000 individuals, and you know what the UK Biobank is. So there is an age range round about between 40 to 80. Half of them, of course, UK Biobank's cohort studies are males. And what we wanted to do in this study is making use of clinical data sets, especially pathology data like NHB and creatinine, CRP, etc., together with clinical data from all organ systems like lung function, like blood pressure, like an MMSE, etc., to really characterize all organ systems. So we use lots of data of that UK Biobank, around about 200 variables. We splitted them up by domains, and you see the domains here, or that's figure A, a brain domain, pulmonary, musculoskeletal, renal, etc., etc. And then say, okay, can we build clocks while using these kind of data sets? And these are just examples, because the list is so long of the variables we used, to actually see, are there differences between the organs in terms of their clocks? Is the intra-individual rate of aging, is that different within individuals compared to the the rate between individuals? And what we did is actually we used this 150,000 individuals, and we selected the ones who were healthy without the disease, and we selected the ones who are diseased, and we split them up on the age-related diseases, and we trained the clock in the healthy individuals while using, I think, nice technology. And then we got the clock, and we validated the clock not only to see if the diseased individuals were biologically older using these different clocks of the different domains, but we also looked at, okay, are these clocks associated with lots of factors we know influencing lifespan, for example. So we used not only physical activity data, nutritional data, genetic data, but we also had access of environmental data, which is, I think, very important. Is there green space in the environment? Are people biologically older using our clocks in areas where there's no green space, for example? So we had a very broad approach, and of course you cannot actually publish a paper without showing that this clock is associated or predictive for mortality, which we also did. So we also not only really established the different organ clocks, but we also combined them together to the body clock. And I will just show you, because we had so many clocks in the end, that the body clock is quite predictive or associated with the chronological age. Of course, because this was our model, so I think it's quite good having an R of a 0.8. I don't want an R of a 1.0, because I can just look at the passport. So I think even in the first generation of clocks, which are modeled based on predicting the chronological ages, it's very important that we have the spread, that it's not a high R. So I'm very happy with that R of a 0.7 2.8, and you see that males and females, there was not much different. And this clock is based on 78 physiological measures. If we then look at the body clock plus the other clocks we created, which are organ-specific, and we looked at determinants of these clocks, so it's a very long list. But what I want to highlight, and at least I learned lots of it, determining what the biological age is using the clocks, there is something with women's health. If you look at the parameters, so the magnitude of that line gives the association, the R, of the effect size. So thicker lines are, it's a more effect size. There is had menopause, where we actually adjusted our models, of course, for chronological age, etc. You see that women in menopause had a much higher biological age. But you also see, which is so important on the right-hand side, maybe you cannot see it, but people who have much more green space around them, they are biologically younger. And of course, this is just an association, but this might be that they are moving more, there's more physical activity, etc. And I think combining all the data sets where you have the environment, you have physical functions, you have social functions, you have psychological function, I think that's a way to go to understand why some people age more rapidly than others. What we also did in that data set, we wanted to know, is there a certain sequence of decline in different organ systems? So as you know, the UK Biobank already has a long-term follow-up, which is nice. So what we did is we looked at the delta of change of a certain organ function. I will just take the example by pulmonary function measured by the lung function, for example. So there's a delta at one point and the other point. A couple of years later, we calculated the delta, and most of the times, of course, function is going down. And then we said, okay, if the function is going down much more rapidly, is that associated with another organ system going down? And calculating again at then the second visit and the third visit, is that actually predictive of a decline of the next organ function? And what we are able to show is in this network analysis, just an example, is if the pulmonary function is going down, it's very likely that also the cardiac function is going down many years later. And then, for example, if the cardiac function is going down many years later, the muscular function is going down. For example, having a decrease and a decline in grip strength or muscle mass, etc. Which means that we now have trajectories of functional decline in individuals. And we could, if we would make use of these kind of data, actually prevent the next step. So if somebody is visiting the cardiologist, it might be that it's good also to do some resistance exercise training and to involve the physiotherapist, because you know that the muscle function is going down. And of course, it's much more complicated, but I think using this data to shape healthcare is of absolute importance, I think, to save also a little bit of money. Coming back to the clock, so here again, just the example of the body clock. Is the body clock predictive of the ones in the future of having a disease? And are the ones with a disease, do they have a lower biological age using our body clock? And yes, it is the case. So here you see a clock on the right-hand side. You see all the diseases, and what you can see, if the ones with Parkinson's disease, diabetes, multiple sclerosis, all these diseases had a higher biological age, so it works actually, the body clock, based on our algorithms. They are biologically older. Of course, this is only the body clock. So how about comparing all the different organ clocks in individuals who either have a disease or not having disease? So in this graph, we are comparing healthy individuals, healthy controls, with the ones who have age-related diseases. And what you can see on the left-hand side, we are starting with the body clock. Everything which is green is significant. And if it's going to yellow, it's even more significant. It's red, it's actually even more significant. It's not bad, it's actually good for the clock. And then horizontally, you see all the different clocks, and then you can see all the different diseases. And what you can see that of course, the color is changing, which is good. By the way, gray is non-significant. But what you are seeing is that individuals, independent of what clock's being used, there is a significant association of a higher biological age and having that disease. Now we can also, because we standardized all the variables, you can compare between clocks and between diseases. So by just looking at the graph, and what you can see if you look at the color coding is that especially the body clock, so looking at all physiological systems, is most predictive to separate the individuals with and without a disease. If we look at the clocks, and we are now looking at the different clocks again. On the left-hand side, again, it's a body clock. On the right-hand side, these are the organ-specific clocks. Are they predictive for mortality, 5 to 10-year mortality in the UK Biobank? Yes, they are. Everything was significant. These are the stars. What you can see is that on the left-hand side, every of the clock was associated, or the higher biological age, with being that or not. So they were highly predictive. Individuals who died during the follow-up had a higher biological age. On the right-hand side, you see it a little bit differently depicted in epidemiological terms, looking at the hazard ratio. And because we standardize, we can actually compare the hazard ratios. And what you can see is that the body clock actually had a hazard ratio to predict if somebody died or not. It's a hazard ratio of round about 1.058, so it's not very strong, I must say, but you see that there are differences within the body clocks, or between the body clocks, and especially the body clock pulmonary function is highly predictive. And I think what I learned actually is we do not yet very often phenotype also in humans, for example, lung function, also continuously, which we integrated in our trial designs. These are healthy, quite healthy individuals. We just very recently with Alex, yes, we applied his clock based on blood biomarkers every clinician has, and we wanted to know, so these are 45 like HB, creatinine, etc., CRP. We wanted to know, using his algorithm in geriatric rehabilitation patients who are very, very frail. I have a big cohort of 2,000 individuals of geriatric rehabilitation patients where around about half of them died within 3 years of time. And what we wanted to know is that clock, the first time being applied in such a frail, very geriatric cohort, is that associated with frailty during geriatric rehabilitation at admission. And what you see if we apply his clock, actually there is an R again of a 0.8, so it's good, or 0.9 even, so it's associated with chronological age. But my patients were a little bit younger compared to the chronological age biologically, and that doesn't really make sense. But this only shows that we need much more data also from frail individuals and much higher ages to be able to improve our algorithms and our clocks. However, even that the alpha is a little bit out of shape because they are biologically younger, there's internal consistency in there. And we showed that, and that's on the right-hand side, because the ones within the group who were biologically older were also using a clinical frailty scale, but also other markers were more frail. So there is a very, very good association between the clocks and the clinical phenotype. And of course, these are just path lab data, etc. We should go further. And just an example, and I think our field needs more systematic reviews. We did a systematic reviews of different hallmarks, so this is one being published, looking that senescence is really associated with chronological age, so that's different in different organ systems. And yes, we know that senescence is associated with different age-related diseases, with all of them, and I think we can nearly close the book because we know it. So now it's the question, do we have, for example, senescence marker on cellular level, for example, TB, etc., cells of fibroblast, which we could implement and we could learn something. That's the reason why we invest quite heavily in a biomarker core, that we standardize all the measurements. We can measure whatever hallmarks we want to. I don't want to have that discussion, but we brought all the bright-minded people together and all the efforts to actually build a core, and we are doing that at the moment to have standardized approaches to measure not only longitudinal cohorts, but also our interventions, and in the end, clinical individuals or patients in this core. I will just finish the talk by having a very, very few slides on interventions, what we are doing at the moment. I don't have the data yet. I think it's very important to include in this audience also lifestyle interventions. And I know these are not drugs, it's a drug intervention, but at least we need to understand if we can improve drug interventions also while improving lifestyle interventions. So we just published a very nice article, I would say, with Jiaming Guo, very talented associate professor, where we looked at exercise and the different hallmarks of aging. And my group, in the past 2 years while COVID, we wrote lots of systematic reviews, really closing the book that every step counts and we have to improve physical activity. I think now is the time to get psychologists in and to make it work with nudges, etc. I think we also have to, and this is not our topic here, patient care, but we can learn from it. We have to learn how do we improve nutritional interventions. And in the past 2 years, with a group of excellent nutritionists, I worked on how do we individualize care, nutritional care in clinical practice, because we already do it. And we do it, I think, in a very wrong way, because we are not asking for goals, we don't ask for preferences in our patient care, and I think we should learn from that. We should learn how do we implement, how do we ask for goals of individuals in longevity clinics, etc. So this has just been published yesterday, that's the reason why I'm showing it. We have to individualize it, we have to learn from others. These are the trials being planned and being ongoing at the moment. Speak to these wonderful people. My trial group partly is here, you see the pictures here somewhere in the audience. So we have a pipeline, as I said, of drug trials, but also supplement trials. We standardize everything. We are very open for collaboration. So if you want and have a good idea, you cannot do it yourself, please be in contact. So we can identify, we can intervene, we have to educate. Join us on all the Thursdays, Brian and myself, to do the webinars. It's on our website. Join us next week. We have a hybrid meeting. Here you see excellent speakers. I'm very proud that we actually convinced also policymakers in the afternoon to talk how can we implement longevity medicine into clinical practice in Singapore first. And we have the audience and we do lots of physical exercise together. Thank you so much.
Oh, one second. Thank you, Andrea. We'll have one burning question from Near.
Terrific, Andrea, and good demonstration of how we can get lots of data and try to clock that. But of course, what we want from clocks is to have as few things to put in there and get, the same result. Maybe one thing. So my question is, when you had your clocks, how many data points were there? And how few do you need in order to get a 0.7 and 0.8 correlation?
Very good point. So we wanted the best of the best model. We wanted to use all the data, so we used 202 variables. You will never do that in clinical practice. But as you say, you are making area under the curves, you try to improve your model. And the improvement of the model is much, much, much smaller if you are adding more variables. And for example, as you might also know, look, very easy variables like a CRP is already quite predictive if you have the high sensitive CRP. If you add, and we didn't do that here, but we will do that soon, if you add other data like omics approaches, epigenetics, we just have to prove that it is of additional value compared to all the clinical data. I fully agree this is not implementable. Don't ask me how do we implement this clock in clinical practice. Don't do that. You can never do that. But it was also to see what kind of variables are most predictive, and which is another paper we are analyzing at the moment, because this is so essential. Because in the end, we have to make it translatable to be used by nearly everybody, hopefully, in a couple of years' time. And maybe the omics approach is not the way to go because for implementation, because it's not the most predictive one. And biomarkers are other biomarkers are much better.
Thank you,
Thank you.
Andrea.